Inner, inner, inner. Okay, I think it is. All right, let's review quickly for a few minutes. A thyroid gland is located in the anterior neck. It produces three hormones. They are thyroxine, triiodothyronine, respectively T4, T3, and calcitonin. These two control cellular metabolism. And when we say cellular metabolism, that's all cells in the body. And calcitonin has one function, which is to decrease serum calcium in the blood. Now, there are four parathyroid hormones located behind the thyroid gland. So we can't see it, obviously. So it's behind the thyroid gland. There are four parathyroid hormones there, which produce one hormone, which is the parathyroid hormone. The function of that hormone is to raise serum calcium levels by breaking down calcium from the bone and putting it into the blood. So you can say the calcitonin and parathyroid hormone are opposite. Okay, so they do opposite functions. As you know, the master gland is the pituitary gland, the posterior pituitary gland. How are T4 and T3 made? Well, we need iodine in order to make them. And sources of iodine obviously are what? Besides salt, iodized salt. Where else do we get iodine? Okay, any seafood contains iodine, from seaweed to any fish contains iodine. Iodine is also, the betadine, those are iodine, and we have our contrast agents, those are made of iodine as well. How are they regulated in the body? It's pretty simple. If T3, T4 levels are low, that means as the blood circulates to the pituitary gland, the gland senses that T3, T4 levels are low. They will increase production of TSH, which stands for thyroid stimulating hormone, also called thyrotropin. And that will keep the hormone levels balanced as a result. So constantly, the pituitary gland will monitor T3, T4 levels and respond by increasing or decreasing the production of thyroid stimulating hormone. Because that's its name, what does it do, therefore? What does the thyroid stimulating hormone do? It what? Thyroid stimulating hormone does what? Okay, stimulates the thyroid glands to produce T3 and T4. Okay. And obviously, if T3, T4 levels are high, what will be the response by the pituitary gland? It will decrease production of TSH, right? Pretty simple. So I already described what T3 and T4 level hormones do, as well as the calcitonin. Let's go straight to the problems. Normally, by the way, the thyroid gland is not palpable. If you feel your neck, you should not feel the thyroid gland. That's normal. Okay, whenever you palpate it and it becomes palpable, that means it's now enlarged and you have a problem. So you may want to see a physician. I won't test you on the because our role here is simply interpreting whether they are high or low. So on the exam, although I'll give you the range as well, but it helps to know, have an idea about what the numbers are. Let's talk about this test. because this is we need to separate this from the treatment. Now, there are two radioactive iodines used. One is for testing, which is RAI 123, and the one for treating hyperthyroidism as well as thyroid cancer is RAI 131. There's a difference between the two. Obviously, 123 versus 131, which is a higher dose. 131. So which one do you think is used for treatment? The 131. 123, they're both radioactive iodine. Both will be swallowed by the patient. So therefore, the patient will be radioactive for a certain period whenever they're taking either one. Obviously, 123 is lower dose, so this one has a lower half-life as well. This will leave the patient's body in a few hours. Your responsibilities, especially with these tests, is to, of course, number one, check if the patient has allergies to iodine. And later we'll add more when we get to the disorders. First problem is a deficiency of T3, T4. Now, there are two forms of this disorder. What can lead to deficiency in T3, T4? The problem can either be primary hypothyroidism or it could be secondary hypothyroidism. The most common form is the autoimmune, which is primary. The problem here is with the thyroid gland. It's autoimmune in nature, so do we know what causes it? No idea whatsoever. We just know that the patient develops some form of autoimmune disorder called Hashimoto disease, resulting in decreased production of T3, T4, because somehow the immune system attacks the thyroid gland, so destroys it, and therefore it produces less T3 and T4. A secondary form, or also called iatrogenic form, is after treatment of hyperthyroidism, which usually involves either radioactive iodine therapy, which I mentioned earlier, or antithyroid medications, or surgical removal of the thyroid gland. So these three are all options to treat hyperthyroidism, and as a result, the patient develops hypothyroidism. A third type is caused by a pituitary or hypothalamic tumor. In this particular instance, the problem is not with the thyroid gland. The thyroid gland is normal. However, the problem is with the pituitary gland. There's the pituitary gland or the hypothalamus, because the hypothalamus sends the signal to the pituitary gland to increase or decrease the TSH levels depending on the hypothalamic measurement of T3, T4. Now, let's take a look at the lab results for each one so that you can distinguish and help interpret the lab results for the patient. So let's start with Hashimoto. In Hashimoto, and then knowing the relationship between T3, T4, and TSH. So normally, if T3, T4 levels are low, what will happen to TSH? It'll be high, right? That's a natural response, and then vice versa. Now, in Hashimoto disease, what's the problem again? Yeah, correct? What's the nature of the problem? Autoimmune, right? So autoimmune. So is the problem with the hypothalamus, pituitary, or the thyroid gland? The thyroid gland is the problem. So here, the thyroid gland physically cannot produce T3, T4. So what will be the response of the pituitary gland? It will do what to the TSH levels? Okay, so that's what you will see in Hashimoto disease. You have low T3, T4 levels and then very high TSH. Any question on that? All right, let's go to the other problem. So let's say the patient has a pituitary tumor or hypothalamic tumor. So the tumor causes an increase in TSH production. So when you look at the patient's labs, what will it show? TSH will be high, T3, T4 levels will be high. Why? Right, the problem is not with the thyroid gland. The problem is with the pituitary gland. So of course, if TSH levels are high, what will the thyroid gland do? It will be forced to produce T3, T4. Okay, so you understand why? Why TSH is high, T3, T4 levels are high? Okay, let's go to the diagnostic testing. Okay, there is no table, so let me explain again. Let's go back to Hashimoto. So in Hashimoto, the problem is where? The thyroid gland. The patient has an autoimmune problem destroying their own thyroid gland. As a result, what happens to T3, T4 production? Decrease. T3, T4 levels will be low. Okay, so what will be the response of the pituitary gland? It will increase TSH levels. Okay, it will keep increasing TSH. However, because the thyroid gland in Hashimoto disease is physically unable to increase T3, T4 levels, can it raise T3, T4? It can't. No matter how high the TSH levels will be, the thyroid gland with Hashimoto disease physically cannot produce T3, T4 levels. It can't produce enough. Is that clear? All right, that's why the labs will look like that. Now let's go to the other problem. What if it's caused by a pituitary or hypothalamic tumor? Now that tumor causes an increase in production of TSH by the pituitary gland. So therefore, what will be the response? In that problem, the thyroid gland had no defect. Thyroid gland is completely normal. The problem is that tumor growing on the pituitary gland. So since the tumor caused the pituitary gland to release more TSH, how will the thyroid gland respond? Increase T3, T4. Any question? Okay. Let's go now to causes I mentioned already. So the three major kinds are Hashimoto, autoimmune, or it could be a tumor. Drugs can also lead to hypothyroidism. Lithium will lower T3, T4 levels. We said treatment earlier, RAI 131, surgical removal, or antithyroid medication therapy. Manifestation, since T3, T4 affects cellular metabolism. So what will happen to metabolic rate in hypothyroidism? Everything will be low. So cellular function will be low. So let's describe the patient's, let's look at here. So hair follicles and subsequently the hair, what will they look like if the metabolic rate of hair growth is decreased? Okay, so they'll have coarse, dry, brittle hair. The tongue somehow enlarges, that it doesn't fit in the mouth anymore. So these patients will look like this. They can close their mouth, but at rest, they will look like this. Okay, because the tongue enlarges. You've probably seen people like this. I know I've seen in the subway. They will have periorbital edema. They will have the weight gain. They'll have, for the female, they'll have problems with menstruation and ovulation as well. They'll have edema in the legs because what happens again to heart function here? Decrease. So what happens to heart rate? And what happens to blood pressure? Drops. Okay, what happens to pancreatic production of insulin? Slows down as well. So everything will be low. Okay. GI motility will be low, so they'll have diarrhea or constipation. So they eat very little, but yet they continue to gain weight. Okay, their metabolic rate is so low that they're like a sloth, right? As far as metabolic activity goes. So they'll be very cold intolerant. They'll sweat less. They'll have mental status also will be decreased. IQ decreases as well. Drug metabolism will also drop. So what happens to medication dosing here? Okay, they'll require more regular or low doses of medications. They'll require lower. Renal excretion of drugs, what happens? Also decreased. Respiration, so the muscle of the diaphragm is a muscle. So what happens to the strength of that muscle? Okay, so the patient will also have decreased respiratory drives. Okay, they'll have hypoventilation and depression, among others. So yes. Hard to tell. Depends really if the patient develops, which eventually they can, if they, let's say, blood pressure drops so low, and what happens to the kidneys? You just finished the exam. So what type? So that means the patient can go into AKI, right? So in that case, if the patient's kidneys can't eliminate BN creatinine, then yes, they'll go into metabolic acidosis. So they're low on T3, T4. So we did testing. We confirm either it's Hashimoto, or if the labs don't prove Hashimoto, they prove all's high, TSH, T3, T4 are high, for instance, or all three are low, TSH, T3, T4 are low, which indicates pituitary problem. Then that means they can do surgical removal of the pituitary gland. But most common though, 90% of the cases are Hashimoto type. So the only way to treat it is to replace T3, T4. It will give the patient T3, T4. This is the most commonly prescribed form, levothyroxine. Now, a warning is, because there are different brands, the patient is advised, and the doctor will also specify on the prescription. He'll check a small box that says DAW, which stands for dispense as written. The doctor will specify the brand of the medication, not the generic name. They will specify a brand, and the pharmacist is required to dispense that particular brand. There is a difference between concentrations, apparently, between manufacturers. Okay, so they must be dispensed as written. Although this says ranges between 75 to 150 micrograms, it's usually dosed in micrograms, but we've seen patients start with 18 micrograms. That's the lowest I've seen. That you can go up to from 18 to 25 and so on. Now, the dose is based on the patient's TSH and T3, T4 levels. Okay, the doctor, we usually go with low dose. The older the patient, the lower the dose, but we always start with a lower dose or lowest dose possible for the patient because this can cause cardiac problems if we accidentally give the patient too much hormone, his metabolic rate, because this is a synthetic form. We don't know how each patient responds to the synthetic hormone. So to be safe, the patient will stay on one dose, and sometimes patients get impatient because they see very little improvement over several months, and the doctors typically don't change the dose less than 6 months at a time. Sometimes they'll go 9 to 12 months on the same dose before they make any changes. Doctors won't agree with the patient about, I want it changed now. Okay, no, it's too dangerous. Problems is usually cardiac in nature. You understand? Okay, so it's dangerous to start the patient with a high dose. So we start low and go up slow. Okay, that's usually the trend in dosing the uh, hormone. So tell the patient to be patient. This will require weeks to months, sometimes even years to correct until we get to the patient's exact dose. Plus, moreover, will the patient stay at the same dose? Because let's say you were diagnosed at 18 years old with hypothyroidism. Will your dosing remain the same throughout your life? Let's say you grew taller, or you got bigger, or you got married, you had children, or you're pregnant now, or you lost a child. Will your dosing be the same? Will your metabolic needs be the same? Like now or exam days, will it be the same? Or so it always fluctuates. So that's another reason why we stay with a lower dose. Okay. This is one of the medications that should never be stopped, even if the patient's NPO. You have two choices. Patient's NPO, you ask the doctor, you tell the doctor, my patient's on high levothyroxine. You ordered NPO. What do you want me to do? So they'll understand. They'll either say, okay, give it with a small sip of water, or he'll change it to an IV form. Is that understood? So what's your responsibility if the patient's NPO, or let's say unconscious, unable to take the hormone? Give it, okay? So ask the doctor, we have to give it somehow. Okay, so if it's unconscious, unable to take by mouth, give it IV. Is that understood? Why do we not skip the medication ever? Remember, this patient has no ability to produce T3, T4. Their only source is this exogenous form. Is that, I mean, what will happen throughout the day if we don't give it? Okay, one of two things will happen. I will get to the complications shortly. So here's the first warning about dosing. Always monitor the patient for cardiac complications. The dose is either too high or too low. Other treatments will be in the form of supportive treatment. So let's say the patient's in respiratory depression, then we give supplemental oxygen, or if needed, we intubate the patient. Okay, we support depending on the patient's symptoms. Blood pressure is low, we raise the blood pressure, right? Patients constipated, what do we give? Okay, stool softeners, fiber, or laxatives. Okay, so this is what we mean by we supportively treat the symptoms. All right. Let's go to the complication. Life-threatening complications are summed up under myxedema. Myxedema, the formal name is myxedema coma. The coma there is actually a late sign. The patient will die from respiratory depression, shock, hypoglycemia, etc. before they go into a coma. Let's look at the causes and therefore prevention. Okay, let's start with the definition. So myxedema is a severe form of hypothyroidism. What do you think can lead to myxedema? Okay, non-compliance with medication. Patients who stop or either intentionally or not, they stop taking the hormones. This is what's going to happen. What could be other causes? Let's say they are taking the hormone, but they went into myxedema. What could have caused that? They're taking the same dose, but then they still fell into myxedema. What could have happened then? Okay, they got sick. Okay, so they got sick, or there's under other forms of stress. So sickness is physical stress, right? Could it also be psychological or emotional stress? Because what happens to your metabolic demands during these periods? So what happens if you were taking the same dose as usual? Is it still enough? No. So those can trigger myxedema. So again, non-compliance with therapy, or the patient got sick, and either physically, psychologically, or emotionally, meaning the patient was subjected to severe stressors, okay, that can lead to myxedema. Now, let's look at the same manifestations will be seen in myxedema. However, they will be in severe form. So here's the manifestations and management. So the patient will eventually go into coma. So first, they'll have depression, diminished cognitive status, meaning they'll have changes in mental status. They'll go from lethargic to somnolence to stupor, and then eventually coma. And these are the other manifestations, because there's respiratory depression, so there'll be respiratory acidosis. Both the patient could also go into metabolic acidosis, narcosis, coma, hyponatremia, hypoglycemia, hypoventilation, hypotension, bradycardia, hypothermia. Are any one of these capable of killing the patient independently? Yes, each one can kill the patient. How much more if you combine all of these symptoms, right? So what do you think will be the first management? Patient's hypotensive. So what's the first intervention? You're gonna give diuretics? Hypo. Fluids, what else? But will fluids be always good here, considering the patient has... We will give... why is desmopressin here? We're not talking about antidiuretic hormone here. This is T3, T4. You mean? Vasopressors, if the patient goes into shock, we can consider vasopressors. The initial treatment really is, what did the patient miss? Why did the patient go into this? The hormone, right? Obviously, if the patient's already hypoventilating, hypotension, bradycardia, is this patient awake? Most probably not. So what will you get? How will you give the levothyroxine? IV. So it'll be given IV first, and then everything else will be supportive. So we give the patient fluids, we intubate the patient, put them on a ventilator if needed, handle the blood sugar, keep them warm. We put warming blankets, all right? And like I said, everything else will be supportive. But what's your main treatment? IV levothyroxine. Any questions? That's it for hypothyroidism. Okay, let's proceed with hyper. This one now is the opposite. Patient now has increased T3, T4 levels. Now, it follows the same pattern as hypo. The primary form, which is the most common, is called Graves' disease, also autoimmune. So this is the counterpart of Hashimoto. This time, instead of the thyroid glands not making enough, the thyroid glands this time are making so much T3, T4. So this patient's labs, what will the lab show? T3, T4 levels will be high. TSH will be low in Graves' disease, right? You follow? Right. What if it's the patient can also have a tumor in the pituitary gland? This time, the tumor is making a lot of TSH instead of less TSH. What will the lab show if it's a pituitary rather than a thyroid problem? High TSH, high T3, T4. All right, very good. Manifestations opposite. So if the patient earlier in hypo was gaining weight, very inattentive, decreasing mental status, lack of interest, low IQ, decreased mental alertness, what will this patient look like? A chicken, okay, like this, always like this, right? The most hyperactive patients you see, they'll be very anxious. They'll have palpitations. They feel nervous. They'll have tremors because the blood pressure's high, heart rate's high. They're heat intolerant. Okay, they're always sweating even in the middle of winter. Hair will also be thinning. So we had coarse, brittle hair earlier, right? So this time the patient will have fine hair because there's increased metabolic rate. So as I mentioned, nervous, restless, they'll have emotional instability. They'll be very manic most of the time, but then when they run out of energy, then they'll go depressive. They somehow have a increased fat deposit behind the eyeball, causing the eyeball to protrude. And this is also coupled with the eyelid retracting back into the orbital sac. So the patient will have, if we had a picture, the patient has, when you look in their eye, they will be missing the eyelids. Okay, you won't see the eyelids. And because the eyeball was protruding, can the eyelid close over the eye to moisturize it? No. So what will happen to the eye? Very dry, red, right? Irritated, painful. So that's something very uncomfortable for these patients. The same as hypo, they'll have reproductive problems. They'll have, by the way, for both problems, more women are affected than men. As far as age, hyper occurs more in younger people, whereas hypo usually it peaks around 40 and 50. But hyper can affect younger people. Like you guys, you're in your early 20s. This is the peak for hyperthyroidism, between 20 and 40. So 20 and 40 are childbearing age, correct? Okay, so what are you doing when you're 20 and 40 years old? Okay, you're in school, okay? You're in school, you have your careers, right? And you're at your peak, right? You're living your lives, and then you develop this. How will this affect you? Right. So you'll start losing weight no matter how much you eat. There's simply not enough time in a day to eat to supply the metabolic rate. So the metabolic activity is so fast, they'll sweat a lot. They'll lose weight, okay, despite ravaging through the refrigerator. There's muscle wasting. There won't be any fat left. They'll have diarrhea. What else? Hypertension, tachycardia. Very short attention span, okay, because they'll be going from one thought to another. So more serious, of course, are the cardiac effects. The patient can go into hypertensive emergencies and even stroke. We described the lab results as well as the manifestations. Let's go now to the treatment. There are 3 options for treatment. The doctor and the patient decides depending on what type they have, whether it's Graves' disease or if it's a pituitary tumor. So the options are drugs, antithyroid agents. There are three. We can use radioactive iodine, RAI-131, or surgical removal of a part or the entire thyroid gland, depending on the problem. So one option is radioactive iodine. Now, this is radiation therapy, a form of internal radiation. So the patient swallows the RAI-131. So therefore, can it enter body fluids? Yes, you swallowed it. So yes, it will enter your anything wet coming out of you, except sweat and tears. But saliva, reproductive secretions, feces, urine will all be radioactive. Is that understood? Okay. It won't be radioactive forever, typically around 2 weeks after receiving treatment. We'll get to the details shortly. For supportive treatment, beta blockers. Now, beta blockers here do not have any effect at all on the thyroid hormones. Are we clear? This is only for what? What does the patient have when they have hyperthyroidism? Hypertension and tachycardia, correct? So the propranolol here is really to treat what? The hypertension, the tachycardia. And of course, the less tachycardic you are, then you can get rid of the tremors, okay? Because the tremors can be really how you feel. You're 20 years old and you're this on the train. Okay, it's embarrassing, right? So this is for symptomatic treatment. Here. So symptomatic relief. Again, does not alter the disease. You still have hyperthyroidism. I forgot to mention, treatment for one can potentially lead to the other. Is that correct? So let's say I ended up with taking too much thyroid hormones for hypothyroidism, for Hashimoto disease. Can I exhibit or develop hyperthyroidism? Yes. What about this one? Can I experience or develop hypothyroidism as a result of treatment? Yes. So radioactive iodine, patient must understand that the therapy does not work right away. Nothing does. So the patient must understand and be patient, have realistic expectations about when they will expect symptoms to improve. Okay, so they must be patient. So just like hypothyroidism, there's no easy fix. It takes months, years before you'll see any improvement. I mentioned that these patients with hyperthyroidism, how old are they? Childbearing age. So before we start radioactive iodine, what must we do? Pregnancy testing, because obviously radiation can cross the placenta and harm the child or the fetus. So we check first pregnancy, and then they're told to abstain from sexual intercourse until the treatment, okay, during the treatment. Besides, the patient is radioactive, so is sexual intercourse advised within 2 weeks of treatment? What if I wear a condom? Still the same, because I need to maintain a 3 feet distance. Okay. So the goal of RAI is to destroy the thyroid gland, and therefore, what will be the result here after treatment? What will the patient develop? You destroy the thyroid gland, so the patient will have hypothyroidism as a result. So this is what I mean by the doctor and the patient agree on the type of treatment, because radioactive iodine will literally destroy the thyroid gland, so the patient will develop hypothyroidism after therapy. Question, John? Pardon? Yes, now down the road, because radiation exposure is one of the causes of cancer, especially leukemia. But they are explained all of these consequences. They're given the statistics, And again, the patient, up to the patient, what therapy they'll choose. So here, as already mentioned, they'll destroy the thyroid cells, and as a result, the patient will develop hypothyroidism. And once they do, then of course they'll be taking hormones for life, right? Because they're now hypothyroid. So here's what the doctor's speech will include. Advantages of radioactive iodine over the thionamides. We'll talk about thionamides next. It has relatively less side effects compared to, because the side effects here are shorter in duration. It's only a few weeks, but the consequence again is patient will have hypothyroidism as a result. But millions of people, millions of women live with hypothyroidism. It's quite common. My wife has hypothyroidism. My sister has it too. Okay, we're interrupted here with a life-threatening complication. So this is the counterpart of myxedema. So if hypothyroidism had a really severe form called myxedema, hyperthyroidism also has thyroid storm, which is a severe form of hyperthyroidism. Just like myxedema, this is also life-threatening. What do you think is the trigger here? Why would someone develop this? Okay, the answer is similar to myxedema. So the patient here usually underwent stress. Now the thing with thyroid hormones is it's not always in the bloodstream. The thyroid gland stores T3, T4 in the gland, meaning it doesn't have to constantly produce T3, T4 levels every minute. It stores it and then releases it as needed. Okay, and then when the storage is running low, then they'll make more. Okay, so that's how the gland works. So if the patient is ever subjected to severe trauma, such as surgery, for instance, we'll get to the surgical option next. So that's included as the trauma. So this can trigger thyroid storm, meaning someone's coming in for hyperthyroidism, and knowing that in mind that they have stored T3, T4, which can at any time be released, triggering a thyroid storm. So think of really high blood pressure, really high heart rate, and what could happen to that patient? Stroke, heart attack, okay, name it. Have kidney injury, right? So it's life-threatening. Patient could literally die. So how do we know that the patient's developing it? Of course, we need to know that the patient has hyperthyroidism, correct? Once we know that, okay, we see if we try to, prevention would be what? How can we prevent thyroid storm? Because this could be any stressful event. Okay, so how do you reduce stress? Let's say you're admitted in the hospital. How do you reduce stress? Okay, so avoid excessive stimulation, right? They're already sweating to begin with, and then the gown will be wet. So how do you keep them comfortable? Okay, keep the room temperature down. What do I do with the wet gown? Okay, change it often. Can you give them cool drinks? Okay, keep an ice beverage close by. What else? What room assignment would be best? Private room, but with location. So let's say this is your station. If you put them near the nurse's station, what will that room be like if it's close to the nurse's station? Nurses talk a lot. They fight at the nurse's station. There's gossip there. There's all of that, right? So you want to put them close to this nurse's station? Not a good idea. Put them as far away from the nurse's station as possible, but make sure you visit them often. Okay, make sure you make rounds at least twice an hour, right? Instead of once every hour. All right, so how do we know they're developing it? First is temperature. Now take note that the temperature doesn't have to be febrile, meaning what if the patient's baseline was 97? So any 1 degree Fahrenheit rise is suspicious for thyroid storm. 1 degree. So let's say my baseline was 97.2. Now it's 98.5. That's technically normal, right? But is that suspicious for thyroid storm? Yes, because it's more than 1 degree Fahrenheit rise from baseline. Extreme tachycardia. Here, the patient is sweating extra, going to the bathroom more often than usual, blood pressure higher than usual, etc. So here are again the triggers. So stress. Is stress the same for everybody? What is stressful for you, Miss Bigum? Besides me? Besides nursing school? Besides me and the nursing school and the exam. Okay, relationships. Is it the same for you? Do you have a relationship problem? Oh, see? So that's what I mean by stress is very unique, right? It's highly individualized. Okay, it's unique for every person. So any illness is stressful, correct? Whether it's physical, psychological, or emotional. Here, surgery, tooth extraction, DKA, all right? So any stressful event can trigger thyroid storm. So here's our management. This will, this can also be used for prevention as well. You don't have to wait for thyroid storm to implement some of these. Like you can cool the patient down. Okay, you don't need the patient to be in thyroid storm for that. So oxygen, fluids. This is the 2 drugs. We'll get to the 2 drugs. There's a table later and to see how they work. Hydrocortisone, this is to suppress. Remember, this is Graves' disease, so they will benefit from a steroid only for a thyroid storm. We do not typically put them on steroids every day. So steroids only are given during a thyroid storm. And then I'll explain why iodine is given, because technically, if you give iodine, what will happen? Patient already has high T3, T4. So if you give them iodine, can that cause or trigger thyroid storm? Technically, yes. But we'll explain what form of iodine this is shortly. Okay, let's finish up because the interruption is over. So let's finish up the precautions for radiation therapy. So I mentioned what fluids will be radioactive. Anything wet coming out of the patient except sweat and tears. Okay, but everything else, saliva. So if I'm eating chicken wings and I only took a bite of it, can my kid finish off the chewy ends? No. Can I feed my patient, my child? Let's say I'm eating ice cream. There's a little, oh, here. Okay, because the saliva, okay, is radioactive. Urine, what if I'm incontinent? What will you do? Okay, make sure I'm incontinent. I wet the bed. Can I wash those sheets together with the rest of the families? Okay, so that's one of the precautions. So if the fluids are in the sheets, the clothes, so you wash them separately. How many of us have our own washer and dryer? I mean, your personal, apart from your parents, from your kids. Only for you?
Oh no, my kids. For my kids.
No, that's what I mean by only yours. Okay, nobody else can use that.
Oh yeah, me and my kids.
No. You have radioactive iodine. Can you wash your kids' clothes with yours?
No,
Okay, that's what I mean. Okay,
all
right. So I have to be washed, and then the recommendation is if you share a washer and dryer, so you have to run the machine empty. Okay, that way it washes off the radiation. No sexual contact. Again, how do you have sex with no contact with fluids, right? And you may have sex 3 feet away? No. Okay, sleeping in the same bed with other people, again, 3 feet, okay? So 3 feet distance. No contact with pregnant women, obviously, and no cups or utensils, silverware. If you're a nurse taking care of this patient, so you follow the same precautions. The distance is 3 feet, and the time is you're allowed up to 1 hour. All right, in the room. So don't stay in the room longer than necessary at a time. I mean, do you have to be there when you're, let's say, talking to the patient? No, you can stay at the door, right? So you only go near the patient if you have to. Let's say, can you start an IV 3 feet away? No, obviously not. So whenever you have to be close to the patient, you have to be wearing a lead apron to protect yourself. All right, these patients are radioactive. Are we clear? Precautions again, how far? And how long should I stay? Maximum 1 hour per shift. Are we clear?
Oh, so that's basically an hour a day.
Yeah, because it's you working for one shift, so
Yeah,
12
no,
hours
I'm thinking like 1 hour at a time.
per day. Yeah,
No,
just per shift, unless you work 2 shifts. Anyway, any questions on the precautions? Okay, let's finish up. Let's go to antithyroid pills now. So there are 2 thionamides. They are methimazole or propylthiouracil, or you can say PTU, that's the short name. It's or, okay? Patient will never be on both. Are we clear? Okay, one or the other. Which one is used depending on the patient, whether or not the patient is pregnant. The patient may have to switch depending on the trimester. The doctor decides though. I mean, we don't have that. This is not, this doesn't need to be our problem. The doctor will change the drug if the patient gets pregnant during therapy. Okay. So it says clearly here that prior to initiating the therapy, we need to check these blood work. Why do you think? What will the drug do then? We have to look at the white count and the liver profile. It will lower the white blood cell count. That means, can this cause bone marrow suppression? Yes, and therefore the liver profile is checked. Obviously, this patient is hepatotoxic. Okay. All right. Here's some precautions about dietary intake. Okay, so the consumption of walnut, soybean flour, cottonseed meal, and dietary fiber can decrease absorption of either drug. Now, let's look at how the drug works. Now, thionamides prevent iodine from binding in the thyroid gland. Therefore, no iodine. Can they produce T3, T4? No. So that's how the drug works. How does it drug work again? Prevents iodine from binding in the thyroid gland. So therefore, no iodine binding, no T3, T4. But please keep in mind, are there T3, T4 level hormones already in the thyroid gland? Yes, they already have preformed and stored T3, T4. Okay, keep that in mind. So therefore, when I take the thionamide, either methimazole or PTU, what will it affect? The stored ones or the future production? Only the future production of T3, T4. It cannot affect the T3, T4 already in the plasma or the one stored in the gland. All right. So here's the details about which one is used in which trimester. Again, I wouldn't test that, but because it really is the doctor that will change the order. But is it important for us to know that it's teratogenic? Yes. So therefore, if a patient's pregnant, should they be taking this, continuously? Okay, they should tell the doctor, and the doctor will decide based on which trimester they are, which one to switch to. Okay. Here are your other nursing responsibilities for each one. PTU, that's your responsibilities. Methimazole. Okay. Now let's go to the iodine. So you'll see three forms of iodine here. We have sodium iodide, potassium iodide, and SSKI, or saturated solution of potassium iodide. They're all iodine. How the drug works is, you know how when you go to a buffet and after 3-4 trips to the buffet, and then someone offers you, hey, here's a piece of pie. You already had 3 trips to the buffet, maybe 4. What will you say? Right. So same idea. If you flood the patient's thyroid gland with iodine, lots of it, this is iodine solution. So let's say, what were you taught in fundamentals whenever you give iodine preparations? How do you give it to the patient? By mouth? Give it with, what does that say there? A straw. Why? It will stain the teeth permanently. So the concept of giving iodine solution to a patient with hyperthyroidism is to suppress the release of thyroid hormone. It's only given to patients who are preoperative or experiencing thyroid storm. So what's the only use of the iodine solutions? Pre-op patients or thyroid storm. Okay. However, because this is iodine, can it trigger a thyroid storm? Absolutely. So here, if you're going to give either PTU or methimazole and iodine, which one will you give first? Look at how these two work. Blocks synthesis of hormone, and I mentioned earlier, they block iodine from binding in the thyroid gland, correct? So, knowing that iodine can trigger a thyroid storm, which one should I give first? I'll give the thionamides first. I'll give either one of these 1 hour later, then I can give the iodine solution. Because once I already have this, and then I give the iodine, will it still trigger a thyroid storm if it can no longer bind? Because I gave one of these drugs. No more. Clear? What do I give first? Either thionamide, and then 1 hour later, give the iodine. Here. So iodine, give 1 hour after PTU or methimazole. Right, last therapy will be surgery. So we've done other things, and then we came to this. Okay, there's no other choice. Your symptoms persist. You have to do surgery. So we're going to remove either part or the entire thyroid gland. Okay. So the patient, of course, will be prepared for this because is this stressful? Can this trigger a thyroid storm? All right, so we have to be ready for that. We have to decrease the chances of thyroid storm from developing because this is very stress producing and it will precipitate a thyroid storm. So what will we do? What will this patient receive in order to undergo surgery? Plus what? Iodine. Remember, iodine is given for Preoperative patients. Okay, so we'll start giving the patients, this will start at about 2 weeks before the scheduled surgery. So the purpose here is to decrease suppresses release of thyroid hormone. So therefore, what does it do to the thyroid gland activity? All of these drugs, they decrease it. Because while we have a enlarged thyroid gland, why is it big? Let's say the penis. Why is the penis big during an erection? Blood flow, okay? So whenever you have increased blood flow to a body part, it enlarges, right? Same exact thing here. When you have an enlarged thyroid, that means blood flow is very high. What will happen if you cut it off in that state? Hemorrhage. Patient will not stop bleeding, all right? So therefore, we can't do surgery. You come in, let's do surgery. No, it will be planned. So for 2 weeks, you'll be on iodine solutions, okay, along with the thionamide. And then once we're ready, so we'll draw blood first. We want to make sure your thyroid hormones are near normal. TSH, T3, T4 are near normal. Once we see that, okay, you're ready for surgery. So pre-op, that's what you do. And then your bulk of your responsibility will be monitoring the patient post-op. Okay, so let's go now to the post-op care. Post-op care is not under hypo, it's under thyroid cancer. Okay. They just mentioned it here, so here's our pre and post-op. Okay, so pre-op, we gave the iodine preparations, right? And then did we give the propranolol also? Beta blockers? Yes. So immediately post-op, now depends on how much of the thyroid gland was removed will determine whether or not the patient will develop hypothyroidism. So if there's a remaining gland left, there's a remaining part of the gland left, does the patient have hypothyroidism? They have we only remove a third or half of the thyroid gland. Does the patient have hypothyroidism? No, they still have a thyroid gland. Okay, so it will still produce thyroid hormones. What if we lost the whole thing? Yes, the patient has hypothyroidism already. Okay, remember what I said with anatomy? What's located behind the thyroid gland? There are 4 parathyroid glands there, producing what hormone? Parathyroid hormone, which does what? What does the parathyroid hormone do? What does it do to calcium? Raise or lower? It raises it. Therefore, if we lose the parathyroid glands from surgery, what will happen to the patient's calcium levels post-op? It will drop. Okay. And as I described earlier, so the thyroid gland was enlarged, right? So therefore, there will be a lot of blood flow to it. So can the patient possibly have hemorrhage post-op? Okay. So first is hypocalcemia. Next complication, post-op complication, hemorrhage. And where is the thyroid gland located? Right here. So where's the incision? Right across here. So I made an incision here, took 2 retractors to open it up like that, and then remove the thyroid gland. What would happen to my airway? Because after this surgical manipulation here, so what will happen to the surrounding tissues? Remember, the trachea is right behind the thyroid. Okay, so there will be airway swelling. And what am I conscious during the surgery? So what is the anesthesia used here? Local or general? I was intubated during this procedure. I had an airway. I was on a mechanical ventilator. So therefore, how much trauma did my airway sustain? A lot. The airway plus the surgical incision all traumatized the tissues around the airway. So can I have breathing problems post-op? Okay, so those are the three you're going to be watching for: bleeding, hypocalcemia, and airway compromise. Okay. Let's start with the post-op positioning. How will we position the patient? I have an airway problem, potentially. Flat, semi, Fowlers or high Fowlers would be best. Right. The tendency is if there's bleeding, will the bleeding be here or run down the side and onto the back? Okay, to the back. So that's why it says here, nurse observes the sides and the back of the neck for bleeding, okay, because of the position. We keep a tracheostomy set at the bedside in case we get airway compromise and we will need to perform a tracheotomy. Of course, there's pain post-op, so we give the patient analgesics. Oxygen should be provided and ready. Should we have suction at the bedside also? Yes, because if we need to intubate and put a tracheostomy, we need suction, right? So far, what what equipment do we need post-op? The tracheostomy set. What else? Suction and oxygen. Okay. All right. We need those three. We also need a few pillows, okay, to support the head and neck. Okay. Then this one's not life-threatening. The laryngeal nerve may be injured during the surgery, so just report that to the doctor. Sometimes it returns, sometimes it's permanent, but we don't know. However, if you're not sure if it's hoarseness, if it's stridor, notify the physician anyway. Okay, because sometimes it's hard to tell between stridor and the voice hoarseness, meaning between airway closure and laryngeal nerve damage. So, oh, I forgot. Also, before surgery on pre-op, I won't be mentioned here because this is under cancer, but under actually here, it's also included here, sorry. So remember, before the surgery, while the patient was hyperthyroid, in a hyperthyroid state, what is their nutritional status? It's the really high metabolic rate. So are they healthy? Because remember the picture, what did it say about their weight? Muscle wasting, so therefore weight loss. So are they healthy? Are they in a negative nitrogen balance if there is muscle wasting? Yes, so they are very malnourished. Now, how will a malnourished patient heal after surgery? So therefore, do we prepare them for this before? Is that included in the pre-op? Yes, so here include the diet under pre-op. The patient will be given high carb and high protein diet. So they'll be given high caloric intake, okay, to prepare them so that they can heal after surgery, okay, because otherwise will they heal in a malnourished state? No. So we kind of, fatten them up, okay, so make them as healthy as possible, give them high calorie meals for about 2 weeks before surgery so that they'll heal right here. And of course, after with all our preparations. Why is it again that the patient can still develop thyroid storm post-op? Simon? Why because we gave them iodine preparations, right? We gave them thionamides. Why is it still high risk for thyroid storm? Correct, the surgery was stressful, but so what? What did we talk about earlier? About the anatomy and physiology? No, we gave thionamides, we gave iodine preparations. What does the gland do with T3, T4? It stores it. Okay? It stores it. Remember, the thionamides and the iodine preparations, do they affect existing T3, T4? No, they will only affect future production. So since the glands store the T3, T4, can they be released during or after surgery? Yes. So always watch for thyroid storm. That's about it. Any questions on... So here, do you still remember signs of hypocalcemia? Severe hypocalcemia is called tetany, right? What are those two signs? Like this, what is this called? And what is this called if I put a tourniquet? Chuso. Okay. So you still remember. All right, children. See you next week. So quiz next week will be thyroid problems.